You can start.
Good evening, everyone. Myself, Dr. Rashmi Shankar, Associate Consultant at Department of Anesthesia, Apollo Group of Hospitals. A warm welcome to today's session of SPOC, Prevention of Lung Cancer, one of the topics in which all of us are deeply interested. Without taking much of the time, it's a great pleasure for me to introduce Dr. Vishwanath, Medical Oncologist, Apollo Hospitals, Bangalore. Dr. Vishwanath is an accomplished medical oncologist with a fellowship from the University of Texas. He has an outstanding academic record with gold medals in DM, medical oncology, where he did from Kidwai Memorial Institute of Oncology, and MD Internal Medicine from KMC. He has published widely in journals with high impact factor and has over 40 international publications. He has won several prestigious awards, including an Abstract Achievement Award from the American Society of Hematology. He has a unique blend of taking his understanding of the molecular nature of cancer to the bedside and giving a personalized cancer care. Sir, it's an honor to have you on board, and I will say a few words about SPOC.
Yeah, thank you, Dr. Rashmi, for that kind introduction, and good evening, one and all. And I will just start without taking much time. I'll just give an introduction about this novel trust, which is Dr. Nanda Rajneesh's brainchild. And we are just trying to do what is possible from our end, but it's mainly Dr. Nanda Rajneesh who has kind of spearheaded this entire organization. So are my slides visible?
Yes, sir.
Okay. So this is, as the Society for Prevention of Cancer, very nicely coined. And as we all know, it's not about treating cancers, because even though treating cancers, we say that many of these early stage cancers can have a long-term survival, but we do end up seeing, as medical oncologists, around 75 to 80% of our cases are all advanced cancer cases, which is stage 4 disease. And we know that in stage 4 disease, it is only about prolonging survival rather than actually trying to cure them, because we've still not reached a point where we can cure this condition. But yes, having said that, there are some curable forms of cancer like early stage breast cancer, very early colon cancer, chronic myeloid leukemia, and germ cell tumors. To a large extent, these patients may have a near normal lifespan, considering that in breast cancer, if they have a good biology. But overall, if you see, there are several cancers which are diagnosed very late. And in that case, it is more about preventing cancer, which can actually reduce the incidence and the burden of this deadly non-communicable disease. So as we know, cancer is growing in incidence, one of the leading causes of death worldwide. And prevention is very important in solving this problem of cancer. So how do we prevent this cancer? It's basically by understanding the various risk factors. And if we can prevent the progression of risk factors, or if we can curtail those risk factors, I'm sure we would definitely do our bit by probably preventing cancer. So it is a not-for-profit trust. We are not a profit-oriented organization. It's a totally not-for-profit trust. with an aim of bringing awareness about the risk factors and prevention of cancer, not just amongst the general population, but also amongst existing cancer patients, how they can prevent recurrence for themselves. And also by creating awareness amongst these patients, they could in turn counsel and create awareness amongst their family members and close friends and known people who and thereby it is like contact tracing. So that way we could develop those patients can also do their bit in preventing cancer. So like I said previously, it all started with Dr. Nanda Rajneesh. Initially when she told prevention of cancer, everyone was like, oh, how can we prevent cancer? But then she gave us one topic to talk in one of the recently held conferences, which I'll come to. And that's when we realized that there's so much about each cancer that preventing these risk factors can go a long way in reducing the burden and as well as trying to prevent them. So Dr. Nanda, as we know, is a GI and breast oncosurgeon. She spearheads this organization, and we have Dr. Mr. Sunil Sethi, who is a Supreme Court lawyer and politician. Then we have a couple of medical oncologists, Dr. Rajiv and myself. And then we have Dr. Monica, who is a surgical oncologist with BGS. And then Dr. Poonam, also she's part of my team, and she's also a medical oncologist. And then we have Ms. Ruchika, who is a nutritionist and a holistic health coach. So all of us have come together and we're trying to do our bit to prevent cancer. And then we have several executive advisors from various walks of life, many doctors, skull-based surgeon, and then Dr. Shri, the radiation oncologist, plastic surgeon, and then we have some business women, and then also people from other walks of life who have come forward to help this cause. And it all started, we had a maiden conference in November of 2021 covering various topics. And we had several speakers, top speakers, including the current Vice Chancellor of Rajiv Gandhi University of Health Sciences, Dr. Ramesh. We also had Dr. Somashekar from Manipal Hospital, and several other great speakers, accomplished speakers, and international speakers as well, who came on who gave talks virtually, as well as several of them physically. And various topics on identifying risk factors, detecting precancerous conditions, and preventing different cancers by all these experts. So that is one way of creating awareness. And the same thing was also publicized very well, because just based on the motto, and because it is little innovative and not the run of the mill, but we're all doing a bit to treat cancer, but what about preventing, how to reduce the burden? So that's where this concept comes in. And following that, this year in the month of June, we all went to Jammu. Mr. Sunil Sethi had organized a conference on prevention of cancer, which was very well attended by people from Jammu, and including doctors several doctors from the Jammu Medical Association attended this. So that way, we are trying to create awareness not only in Bangalore, but also in various parts of the country. And we are also have several conferences lined up, or the CMEs lined up in various parts of the country to spread awareness. So, and then again, Dr. Nanda has taken the lead to come up with the cancer prevention prediction app to basically to analyze various factors that can contribute towards cancer and predict the individual risk of acquiring cancer. And then all of us have contributed, several of us have actually contributed to a textbook, which is mainly on the prevention of cancer. And that is going to be launched soon, maybe in the next couple of months. And when I penned an article on a chapter on prevention of leukemia, lymphoma, and myeloma. So when I went into it, I realized that there's so much of risk factors which can be actually which are modifiable and which can be prevented, and which can kind of go a long way in preventing these cancers. And then we also have some yoga classes. Yoga, as we know, actually is very useful. And we have Ms. Ruchika, who participates in these yoga sessions and who teaches patients and also individuals who are interested on Mondays, Wednesdays, and Fridays. And then we are also doing some mass awareness programs about various aspects of pediatric cancers, and also educating the parents. And lectures in schools, educational institutions, and corporate companies. These are very important because the bulk of our urban setup, if you see, corporate companies are very important, and then educational institutions, schools. So trying to cultivate good aspects, basically the role of yoga in preventing cancer, so that it becomes part of your life. And then role of improving immunity. How can we improve immunity? By basically diet and nutrition and other aspects like sleep. Having a good sleep is an underestimated thing. It's very important that we have a good sleep, because by having a good sleep, we know that it ultimately boils down to anti-inflammatory, and we know that inflammation is very important causative factor for cancer. And then lifestyle practices and the role of early detection of precancerous conditions and various other preventive strategies. So we know, so basically it boils down to this: how can we modify the risk factors like smoking, alcohol, prevent smoking, alcohol, safe sex, promoting safe sex, and then vaccination for hepatitis B, hepatitis, and HPV now for cervical cancer, and promoting physical activity, telling kids in schools, and then the importance of yoga, the importance of nutrition, eat healthy, avoid junk, the importance of sleep, positive attitude, and happiness, and then screening, and also some risk reducing surgeries in family members who already like running mutations like BRCA mutation. What about their family members? Can they undergo some risk reducing surgeries? Giving some giving some education regarding that. All these are aspects which are very important and which can go a long way in preventing cancer. So we would like to undertake these projects to improve the awareness amongst the common man and in patients who already have cancer, regarding the different cancers, the risk factors, and preventive strategies. And we would also like to thank everyone involved in bringing up this foundation and supporting us in all these endeavors. And we have a website in place, and we are all reachable. And please reach out to us at info@societyforpreventionofcancer.com, and we are happy to help and also be part of activities which could be of use to prevent cancer. Thank you so much. Thank you, Dr. Rashmi.
Thank you, sir, for those insightful words. A warm welcome to all of them who have again joined us now. Now moving ahead, to introduce our honorable speaker for today, Dr. Medha Sugara, who's an associate professor, surgical oncology at St. John's Medical College and Hospital, Bangalore. Dr. Medha has an outstanding academic record with various publications and awards. Dr. Medha has graduated MBBS from St. John's and her master's in Bangalore Medical College, MCH in surgical oncology at Kidwai Memorial Institute of Oncology. In 2012, she's also achieved her fellowship in advanced laparoscopic surgery, robotic surgery, awarded by the Indian Association of Gastrointestinal Endosurgeons. Her special interests are in the field of colorectal cancer, gastrointestinal malignancies, breast cancers, and head and neck cancers. She's been a part of many organizations, one of which being SPOC. It's a boon to have you here with us today, ma'am. We now request you to start the session today, ma'am.
Am I audible?
Yes, ma'am.
Thank you, Dr. Rashmi, for those kind words. I shall begin by sharing my screen. Is my screen visible to all?
Yes, ma'am. Yeah.
Hello and a very good evening to all of you. I begin by thanking SPOC, especially Dr. Nanda Rajneesh, for giving me this opportunity to talk on prevention of lung cancer. Today, I represent my institution, the Oncology Center at St. John's Medical College. I begin with this quote from Charaka Samhita. A physician who fails to enter the body of a patient with the lamp of knowledge and understanding can never treat diseases. He should first study all the factors, including environment, which influence a patient's disease and then prescribe treatment. It is more important to prevent the occurrence of a disease than to seek cure. For a doctor, treatment may be of primary importance, but a doctor who is a healer in the true sense understands the importance of prevention of diseases. And it is with this thinking that the Society for Prevention of Cancer has been formed. So coming to the topic in question, that is, how do we prevent lung cancer? Globally, lung cancer is the largest contributor to new cancer diagnosis, second only to breast cancer. In 2018, there was an estimated 2.1 million new lung cancer diagnoses. This accounts for approximately 12% of the global cancer burden. Lung cancer is the largest contributor to death from cancer. Approximately 18% of the total cancer deaths can be attributed to lung cancer. In India too, lung was the leading site of cancer in metropolitan cities and the southern region. This is data from the cancer registries. Although there has been some improvement in survival during the past few decades, the survival advances that have been realized in other common malignancies have yet to be achieved in lung cancer. Approximately 44 to 48% of the lung cancers are diagnosed in stage 4. And this is why the overall 5-year survival rate of lung cancer is dismal at around 15%. Briefly, let us look into the carcinogenesis of lung cancer. What happens in reality is that inhaled carcinogens create a field of injury in all the airway epithelial cells lining the respiratory tract. This brings us to the concept of field cancerization. So what is field cancerization? It refers to the presence of histologically normal appearing mucosa harboring molecular abnormalities adjacent to the main tumor. This is what makes treatment of lung cancer challenging, in addition to other problems. The inhaled carcinogens form DNA adducts and lead to mutations in the epithelial cells. The result is formation of clones with a capacity to grow indefinitely. So what are the type of cancers we see? Small cell lung cancer and non-small cell lung cancer are the two main types. The small cell lung cancer, which constitutes about 15% of the total lung cancers, are lethal cancers, which are commonly diagnosed at an advanced stage. And 97% of these cancers are associated with exposure to tobacco smoke. On the other hand, non-small cell cancers, which constitute about 80 to 85%, are a mixed type of cancers, adenocarcinoma being the most common one, followed by squamous cell carcinoma and large cell carcinoma. So over the years, adenocarcinoma has become the most common type of lung cancer. However, prior to the 1990s, squamous cell cancers were the predominant type. These trends are based on the US SEER data. SEER refers to surveillance epidemiology and end results data. And this graph here shows the trends from the 1970s to 2016. Depicted in light blue is the age-adjusted incidence of adenocarcinomas, squamous cell cancers. And what we see is that before the 1990s, squamous cell cancers were the predominant type of cancer. And over the years, adenocarcinoma has become more common. A similar pattern has been reported in India by the Department of Oncology from AIIMS, New Delhi. So what is this difference between squamous cell cancer and adenocarcinoma? Squamous cell cancers are more centrally located and they affect the main trachea and the large bronchi. On the other hand, adenocarcinomas are located peripherally and they affect the distal bronchioles and the alveoli. So what happened is, in the early 20th century, most mass-produced cigarettes were non-filtered. This discouraged deep inhalation, and the combusted tobacco smoke exposed primarily the trachea and the bronchus, resulting in observed higher rates of squamous cell cancers. When filtered cigarettes were introduced, combusted tobacco smoke dispersed deeper into the respiratory tree due to the deeper inhalation, resulting in adenocarcinomas with a more peripheral distribution. So the introduction of the light cigarettes or the low tar cigarettes had the paradoxical effect of increasing rather than decreasing the lung cancer. Recently, we have seen a change in the smoking trend too. There has been a rising trend of female smoking, which has been reported from Singapore and Japan. Central Europe and Eastern Mediterranean countries have a high prevalence of smoking among women. In India too, smoking among women has doubled from a 1.4% to 2.9% in the last decade. So the key to prevention is gaining a good understanding of the risk factors, and we shall begin with understanding the risk factors in lung cancer. So here I have listed out all the risk factors for lung cancer, the top one being tobacco smoke. The figure in brackets indicates how much that particular factor contributes to lung cancer in the population. As you can see, 85 to 90% of the lung cancer can be attributed to tobacco smoke. This is the reason lung cancer is considered a preventable cancer. If we have our tobacco problems sorted, we are done up with lung cancer. We will have very, very few cases of lung cancer. Apart from tobacco smoke, occupational exposure, radon, air pollution, and exposure to secondhand smoke are the other risk factors. I shall talk about this in detail in the subsequent slides. So there is no doubt that smoking kills. And we are thankful to Dolan Hill, who concluded through their case control study on 20,000 doctors that lung cancer is caused by smoking. This finding was further endorsed by the US Surgeon General in 1964, when they released the report of the Advisory Committee on Smoking and Health. Following this report, a drastic change in the per capita cigarette consumption was seen in the United States. As you can see in the graph, the black line is showing a dip following the 1960s. And a few decades later, the lung cancer death rate in males and females show a declining trend. And this trend continues to this day. So very often I am asked by patients, what is the risk associated with tobacco smoking? How do we quantify it? So compared with lifetime non-smokers, the relative risk of lung cancer in a long-term smoker is estimated to be around 10 to 30-fold. And the magnitude of lung cancer risk is related to the smoking intensity, the number of cig pack years, and the types of cigarettes consumed, the age at onset of smoking, the degree of inhalation, the tar and the nicotine content of cigarettes. All these factors become important to determine the magnitude of lung cancer risk. Various lung cancer risk models are available as web-based tools that provide risk assessment based on demographic information and smoking history and intensity. 1 in 9 smokers eventually develops lung cancer. This doesn't mean the other 8 do not develop any type of cancer. Smoking does lead to a number of other illnesses and cancers like urinary bladder cancer, pancreatic cancer, esophageal cancer, and leads to chronic bronchitis, inflammatory conditions of the lung, COPD, and emphysema. So we'll understand a few terms here related to smoking. The mainstream smoke, which is produced by inhalation of air through the cigarette, is the primary source of smoke exposure for the smoker. The side stream smoke is produced from smoldering of the cigarette between puffs, and this is the major source of environmental tobacco smoke. Why is it so difficult to quit smoking? The primary determinant of tobacco addiction is nicotine, which is easily absorbed by the mucous membranes, skin, gastrointestinal tract, and the respiratory airways. And this nicotine acts as a neurotransmitter that in turn stimulates the release of dopamine. And it is this dopamine which contributes to the feeling of pleasure, happiness, and satisfaction as a part of the neurological reward pathway. So we see that it is a behavioral problem, and that is why it's so difficult to address. Tar is the total particulate matter of cigarette smoke after nicotine and water have been removed. And it is the exposure to this tar that seems to be the major component of lung cancer risk. So what does the tar contain? It contains about, the tar and the cigarette smoke contains about 4,000 chemicals. And out of these, about 70 of them are established carcinogens. Polycyclic aromatic hydrocarbons and nitrosamines, aromatic amines, and aldehydes are listed carcinogens. Apart from this, heavy metals like cadmium, polonium are also found in the tobacco smoke. Often I'm asked by my patients, I have smoked for so many years, is there any benefit of quitting now? It's important to understand quitting at any stage is beneficial, not only to prevent lung cancer, to prevent a whole lot of other problems associated with smoking, because smoking contributes to the cardiovascular diseases. It contributes to peripheral vascular diseases. It contributes to chronic bronchitis, chronic lung conditions. So smoking cessation results in reduced risk of all histological types of cancers, particularly the lethal small cell lung cancer and the squamous cell cancers. And the reduction is more pronounced in heavier smokers, especially women. The risk of lung cancer in former smokers is decreased by 50% within the first 15 years after quitting. And up to 20% of the cancer deaths worldwide could be prevented just by elimination of tobacco smoking. Coming to the element of environmental tobacco smoke or secondhand smoke. So the secondhand smoke, which is produced from the smoldering end of the cigarette tip, contains multiple polycyclic aromatic hydrocarbons, nitrosamines, and aromatic amines. And studies have shown that nicotine and its metabolites are present in the urine of never smokers who are exposed to secondhand tobacco smoke. And a dose-response relationship between lung cancer and environmental tobacco smoke has been confirmed. So there is no safe level of secondhand tobacco exposure. Most studies have focused on non-smoking spouses, especially women, because workplace exposure and social exposure is difficult to quantify. So a meta-analysis published in 2018 found that secondhand smoke exposure was associated with 25% increased risk of lung cancer. Coming to the topic of electronic cigarettes. Often the adolescent youth in the cities ask this question, is it safe to use electronic cigarettes? It has become more of a fad these days to use electronic cigarettes. So ENDS, or the electronic nicotine dispensing systems, have been marketed as a less harmful alternative to conventional cigarette smoking and as a smoking cessation technique. In 2013, the US FDA market gave authorization to electronic cigarettes as substitutes for quitting smoking and cigarette substitutes. The United Kingdom also advocates e-cigarettes as a medicinal quit aid, but bans it from social and workplaces. India, along with many other countries, still needs to come up with a formal regulatory stand regarding e-cigarettes. But the question is, do e-cigarettes really help for smoking cessation? So this trial published its results in 2019, and it compared the nicotine replacement therapy versus e-cigarettes. And they found that with the use of e-cigarettes, the quit rates or the abstinence rates were 18% compared to just use of nicotine replacement therapy, where the quit rates were 9%. However, the replacement therapy needs to be combined with behavioral therapy, and the quitters became dependent on e-cigarettes. So the question comes now, is e-cigarettes safe for long-term use? And we have no answers for that, as you will see. So what exactly is an e-cigarette? It consists of a cartridge filled with an e-liquid or electronic liquid, and a heating element or an atomizer, which is necessary to heat the liquid to create a vapor that can be inhaled through the mouthpiece. Because e-cigarettes are combustion-free, and because most of the damaging and the well-known effects of tobacco are derived from combustion, there is a common assumption that e-cigarette consumption or vaping is safer than conventional cigarette smoking. However, are they really risk-free? So what I generally tell people is neither smoking nor vaping is beneficial to health. The number of chemicals in e-cigarette smoke might be lesser than a regular cigarette, but the vapors from e-cigarettes do contain respiratory irritants, toxic substances, and also carcinogenic compounds. The long-term effects of vaping are not known, but when we come to the short-term effects, there is a report from the US Center for Disease Control and Prevention. In 2019, they reported an outbreak of e-cigarette associated lung injury, which caused several deaths in the young population. This was associated with the use of tetrahydrocannabinol and vitamin E acetate as a component of the e-liquid. And now this has been banned. Also, there is the risk of nicotine poisoning, because e-cigarettes are widely available in different nicotine concentrations, varying from 8 to 24 mg per ml per cartridge. And even doses up to 100 mg were readily available until some time. And this poses a real risk of nicotine poisoning. Multiple studies have also demonstrated the negative effects of vaping on the respiratory and the cardiovascular system. Coming to the occupational exposure. We are all living in this age where just at the click of a button, everything is available to us. This is the industrialized age, where we are living comfortable lives, but this comes at a price. And the price is paid by the workers in the industries, mining, quarrying, coal industries, metal production industries, shipbuilding industry, and the construction industry. These workers are at a very high risk for lung cancer. A word about asbestos production, because this is associated with a very, very high risk of lung disease and cancer. So asbestos has always been in the news for some or the other reason, because we have not been able to do much related to the ban on asbestos. So what exactly is asbestos? It is a naturally occurring fibrous silicate mineral that has fire retardant and anti-corrosive properties. And it is for this reason that it is used extensively in industries. It is basically mined from quarries and then incorporated into manufacturing sheets, roof sheets, low-cost building material. When asbestos is inhaled, it becomes permanently trapped in the body and it incites inflammation. This chronic inflammation leads to cancer. With exposure to both asbestos and tobacco, there is a synergistic effect, and the risk of lung cancer is increased 15 to 50-fold. So what can we do for protection of our workers? Apart from smoking cessation, use of protective devices, educating them, and using some engineering measures to prevent air pollution. Legislation on the use of carcinogens in industries is very important. Stringent enforcement of occupational health standards is equally important. So the other risk factors include respiratory diseases, tuberculosis and pneumonia incite inflammation in the lung. And although this is not a chronic inflammation, it generally resolves. The odds ratio of lung cancer with the pneumonia or tuberculosis infection has been reported to be in the range of 1.4 to 1.7. COPD or emphysematous diseases have smoking as a confounding factor with lung cancer, and it is therefore very difficult to assess the risk of lung cancer in these patients because generally they all have a smoking history. Radon is a radioactive gas that is found in the soil due to decomposition of thorium and uranium. And this is found mainly in quarrying areas and in construction areas where which involves deep digging into the earth. Certain geographic areas are have a rich content of radon, and this risk is significant in the US, where about 10% of the lung cancers can be attributed to radon exposure. Air pollution is always in news, but are we really doing enough to control air pollution levels? What are the problems with epidemiological studies in air pollution and lung cancer? The problem is that the effect of air pollution on lung cancer manifests only decades after exposure. We will not know it now. And we have too many confounders. The changing spatial distribution of the pollutants make a measurement of the exposure factor very difficult and challenging. But we do not need epidemiological studies. The most impressive example of the severe adverse effect of air pollution was the 1952 Great Smog of London, during which thousands of persons died just in a week from heavy pollution. This led to the implementation of Clean Air Act 4 years later, and we see the effects of this in Europe and UK. So what happens? How does air pollution contribute to lung cancer? So the air contains known and suspected human carcinogens, and these carcinogens get absorbed onto the carbon-based particles and are then inhaled and trapped in the lung. So the particulate matter content in the air is the significantly associated with the increase in lung cancer. A significant amount of never smokers also land up with lung cancer. And why is that? In the Indian scenario, indoor air pollution and use of domestic or biomass fuel exposure may be one of the causes. Two epidemiological trends which we see in lung cancer in never smokers is that women are more often affected and it is more prevalent in Asia. This study from China on the household ventilation and how adequate ventilation can help decrease lung cancer incidence is important. It says that household ventilation, in addition to tobacco cessation, should be considered as one of the public health measures for prevention of lung cancer. So how does ethnicity and genetic predisposition affect lung cancer? So if there is a family history of lung cancer, the risk of lung cancer in the individual in the family increases by more than 50%. Apart from this, about 80% of the lung cancers occur in persons with tobacco exposure, and fewer than 20% of the smokers develop lung cancer. Black men have higher rates than white men, and Asians and Americans, Indians of both sexes have lower rates than whites. Why this difference? So we all have different capacities to metabolize and detoxify carcinogens within us. And this is very dependent on the polymorphisms in glutathione S transferase and the cytochrome P450 liver enzymes. And it is this balance between activation and detoxification that affects the individual cancer risk. So till now we were discussing about all the factors which can cause cancer, but are there factors which can help decrease your risk of cancer? So fruit and vegetable consumption is known to decrease the risk of lung cancer. So also physical activity can reduce lung cancer risk by 30 to 40%. Very often I'm asked by my patients, is there a magic pill to prevent lung cancer? Because quitting the smoke is very difficult. So if there is a pill, it would be wonderful if it can prevent lung cancer. So a number of vitamins have been tested: vitamin E, beta carotene, selenium, they all have been tested. And it is found that even with 5 to 8 years of dietary supplementation, there is no reduction in the incidence of lung cancer. So there you have your answer. There is no quick fix for lung cancer. So what can be done? Tobacco cessation is the answer. Here at St. John's, our psychiatry department does offer tobacco cessation services on most days of the week. And as physicians, we have a responsibility to offer this to all our patients who are dependent on nicotine. So what is the rationale? Rationale is to reduce craving associated with nicotine withdrawal. And among all the drugs that we have, varenicline has emerged superior. This trial demonstrates the efficacy of varenicline. This was a placebo-controlled trial which compared nicotine patch versus bupropion and varenicline 1 mg at a twice daily dose. And they found that the abstinence rates of varenicline treated participants were higher, and they were in the range of 40 to 45%. But this abstinence rate is not sustained, and the relapse rates of about 19 to 20% have been seen. To prevent relapses, nicotine replacement therapy may be used along with varenicline. What else can be done for lung cancer? Screening. Let's talk a bit about screening for lung cancer. So why is it important to screen lung cancer? About 79% of the patients with lung cancer present at an advanced stage, and only 17% of the patients present with localized disease, and only they are eligible for surgery. And early stage lung cancers are the ones that are associated with an improved survival. So screening can help us pick lung cancer at this stage. Also, we know the high-risk group for whom the benefit is intended, and the high-risk group in this case is quite large. So the rationale for screening is quite clear. But how practical is it, and what can be achieved with screening? So early screening trials in the 1970s were based on chest X-rays and sputum analysis, and they showed no mortality advantage. And recently, the Western countries and the European countries conducted many trials using low-dose helical CT as a screening tool for lung cancer. The National Lung Screening Trial and the Nelson Trial are the only two adequately powered trials to detect a mortality benefit. However, most countries like Germany, Denmark, UK, Italy, they have all conducted their, even Japan, have conducted their own lung cancer screening trials. So the US National Lung Screening Trial found that a 20% relative reduction in lung cancer mortality with the use of low-dose helical CT. They studied this in 53,000 participants, and they used only the high-risk population for this. So who should undergo screening? High-risk group, that is persons aged 55 to 77 years who have smoked for at least 30 years, 1 packet per day, and current smoking individuals, or those who have quit within the past 15 years. The investigation of choice is the low-dose CT or the helical CT. Entire CT can be surveyed in a single, entire chest can be surveyed in a single breath, holding for 7 to 15 seconds. There is reduced motion artifact, and the radiation dose is 1/10 of the diagnostic dose. What is the screening interval suggested for this? Yearly CT scan is suggested. One can stop screening once the person has not smoked for 15 years or has a health problem that limits life expectancy or the ability to have a lung surgery. How is one to implement screening? A shared decision-making is important, and all current smokers should receive smoking cessation interventions. Now, what are the pitfalls of screening? It appears all rosy to say, since you're in the high-risk group, get a CT scan done every year, and let's see. This is going to help you prevent lung cancer, and we can cure you of it. The problem is that the false positive results are very, very high. The US trial showed a false positive rates of 26%, and the Nelson trial showed false positive rates of 19%. This means unnecessary tests, invasive procedures, overdiagnosis, and increased anxiety and distress in patients. So what is the scenario for screening for lung cancer in India? There is this study which is published in the Indian Journal of Radiology and Imaging. They chose around 300, and it's a retrospective study on 350 high-risk group smokers. This was done in a private hospital in Mumbai. They found that out of the 350 patients chosen, 90% of them had some or the other lesion detected in them. They used the Lung-RADS system of scoring to assess the risk of lung cancer, and about 7 of the 350 people had lung cancer. So this correlates to around 2% prevalence of lung cancer. When you compare this with the US data, they have a 1% prevalence of lung cancer. So we can see that a large number of people are subjected to unnecessary anxiety and distress because we do not know the significance of the lesions we find on the CT scan. In India, this is a significant problem because we have a high incidence of chest infections. Misdiagnosis is often because tuberculosis is a mimic, and CT scan does come with a prohibitive cost and logistic for a large segment of the population. So presently, we do not have screening guidelines, but as a rule, if I see a high risk patient who is eligible for screening in a high risk group with adequate counseling and explaining the side effects of screening, one can suggest screening for lung cancer. So what is the ideal screening method? We still seem to be looking for it. An ideal screening method should be easily and widely available, should be easy to perform and cost effective. So for India, possibly a digital chest X-ray with a computer-aided diagnostics could increase the sensitivity, because we do understand that the conventional chest X-ray is not useful. They are very operator dependent, reporter dependent. The mediastinum and the heart shadows can obscure lesions which should be detected. But with computer-aided diagnostics, one can possibly improve the sensitivity of the digital X-ray. PET scan is another option, but it has prohibitive costs, and it can be used only for lesions more than 7 mm or 1 centimeter. Molecular biomarkers are being studied. So the exfoliated cells in the sputum can be checked for certain epigenetic changes. However, these are all in the preliminary stages, and data regarding this is very limited. Autofluorescence bronchoscopy has also been suggested as one of the modalities of screening, because the diseased epithelium emits a different kind of fluorescent light when compared to normal epithelium. The other modality which has been studied is the electronic nose. It has been found that patients with lung cancer exhale aldehydes and aromatic compounds, which can be picked up very accurately using these aldehyde detectors. However, its efficacy in the large scale is not known. So coming to the role of policy makers and law, this was in news recently. New Zealand has completely banned cigarette in their country. And this became a controversy because livelihoods of a lot of people get affected by this. So this is where the role of policymakers and law comes into play. In 2003, the COPTA Act was passed, which prohibits tobacco advertisements through most forms of mass media. And since 2008, smoking has been prohibited in many public places across India. As of 2016, India implemented pictorial warning coverings covering more than 85% of the cigarette packaging. And cigarettes are now classified as a luxury good, resulting in a tax rate of 28%. But are these measures enough? No, they are not. And we need to do more in this aspect. Measures are needed with regard to control of air pollution too. In conclusion, I'd like to say that lung cancer is a preventable cancer. Screening with low-dose CT is safe in high-risk groups. And as clinicians, we have a responsibility to address tobacco use by screening high-risk patients and offer cessation support. Thank you.
Thank you, ma'am, for that very knowledgeable session. A recorded version of this webinar will be available, and we'd love to hear from you. And if any of you all have any queries or questions, our speakers would be able to clear your doubts. I repeat myself, any questions? You can also drop in your questions if you all have anything later on. Thank you everyone for your patience hearing. Thank you, ma'am, for this knowledgeable talk. Thank you, Nanda ma'am, for this opportunity for all of us. Have a good evening ahead. Thank you, one and all.
Thank you. Thank you, SPOC.